Good afternoon, everyone, and welcome to UNC Health COVID-19 Game Changers, Session 9. My name is Leslie Nelson Bernier, and I have the privilege of serving as the president of UNC Health Foundation, and we're delighted to have you here with us this afternoon. Many of you have been with us in the past for these sessions, and you're in for another real treat today. I want to just encourage you to use the chat function and the question and answer function to ask questions of our panelists and certainly chat amongst ourselves. We really want this to be an interactive experience. And as I said, you're in for a real treat today. I have the privilege now of introducing our Executive Dean for the School of Medicine, Dr. Christy Page, and she's going to tell us a little bit about our speakers today and give a little bit of an update on how things are going at UNC Health. Dr. Page?
Thank you, Leslie, and good afternoon, everyone. Thank you for taking the time to join us, and thank you for being part of our UNC Health Foundation family. It means so much that you are a part of our work and that you are a part of our family and that you're with us today. I'm Dr. Christy Page, Executive Dean of the UNC School of Medicine. I am delighted to be here with two of my close colleagues, Dr. Cené and Dr. Robb Malone. Crystal and Rob have been incredible leaders for us over the last year, and they'll introduce themselves a little bit more later, but even before we received the first doses of the vaccines, Crystal and Rob were working to make sure we had plans in place to get these doses to the communities, especially those that have been disproportionately impacted by the virus. And since then, they have worked truly tirelessly, removing barriers, helping enhance access and appropriate communication, and helping to vaccinate people in our state just with easy access to health services and the right information. So I look forward to transitioning to them in a moment. But as Dr. Burks has done during our previous Game Changer sessions, I'll just offer a little bit of an update to the current state of our COVID-19 response across the UNC Health system. In total, we've given more than 250,000 vaccines to date, and that is a testament to the thousands of people working incredibly hard. Our staff, numerous volunteers, too many to count, volunteers at the Friday Center and other vaccine sites across the state. Our mobile clinic, with both Rob and Crystal are part of, but that mobile clinic takes the vaccine directly to communities that need it. And it's just been inspiring. I've been proud to watch our teams lead in vaccine distribution, and certainly even more proud of seeing work like what Crystal and Rob are about to describe, so that we can be proactive about improving the health and well-being of North Carolinians. I'd also just like to take you a moment to update you on how our students at the UNC School of Medicine have really risen to the challenge that has been facing them over the last year. None of our students could have imagined what was in store for them, and just thinking back to last spring, and their resilience is just so impressive and exciting to think about the future physicians across our state. Last week was our annual match day, where the medical students, the fourth-year medical students, find out where they're going to train in residency. And this is a big event that we normally have in person. People get their little envelope that tells them where they're about to move their family to. And we were able to do it virtually again. And that really was a testament to their flexibility and resilience over this time. They had to choose their rank list of where they wanted to go and train, often based on only virtual meetings, only virtual experiences with the people that they're going to join. And so that resilience has really been remarkable. We're so proud of our students and so delighted to have a very, very successful outcome for them. And I understand that y'all have had some wonderful conversations in the past about everything from baking and cooking to many other casual topics. So we thought that we would at least share a little bit of our own personal experiences have been over the last year, and how our lives have changed since last March. So before I turn it to our speakers to reflect on that, and then kick off their presentation, I thought I should probably share my own. And that is, I'd say at work, I have been more inspired and grateful to be able to work in a place where we can be a part of the answer, where there could be a global crisis. And I work alongside the most remarkable people who aren't just, they're forward facing with patients, supporting and suffering with patients, but also to be the hub of COVID vaccine research and really be able to have done the science in advance of this, to then have the science needed to create the immunizations and vaccine strategies, to be able to work alongside these creative educators and students who have adapted to all of this. There's something about that has fueled me through it, that not many people get to work in a place like that. And so that has been really meaningful to me to reflect on and to carry me through during this year. I'd say I'm kind of ready for COVID to be over, but unfortunately we're coming just to a new normal. So for my family, I have a 15-year-old daughter, Caroline, and a 13-year-old son, and my husband's an emergency physician. And I could tell you that now that he's been vaccinated, and I have too, there's just sending him off to work feels a little bit less stressful than it did before. And having our kids in school in person has made a big difference to our lives. So we're hitting the spring and hoping that, we're going to put most of the hardest parts of this thing behind us and move forward. So that's kind of the space I'm in at this moment. But now let me turn it to you, Robb, to tell us a little bit about how you're doing personally and how your family has adapted.
Thanks, Christy. Am I coming through okay?
Mm-hmm.
Volume? Great. I'm doing really well. If you know me, I'm a glass half full kind of person anyway. But I feel blessed because my family and I both are healthy, safe, and secure, and honestly really insulated from COVID. I've not seen some of the struggles or adverse effects or illness that others have. And I'm very fortunate for sure. Interestingly enough, those of us that work for UNC Health know that there's a big focus on well-being of our employees. And if you can't take care of yourself, you can't take care of others, is sort of the mentality. And one of the tools we use is this called a well-being index. And it's a little app that you take a quiz on every month or so, and it tells you where you're at compared to your colleagues. And for the first time, I was thinking about this, Christy, for the first time, I think ever, I was an average scorer on that tool. And I reflected on why that was, right? Because normally I'm, above average and doing really well. And it really, to me, was the same things that are leading me to do well and say that I'm happy and healthy are also some of the things that drive some of that lower performance on that tool. I think, and I reflected on that, my well-being is threatened because sometimes I feel a bit guilty because being so insulated, and, a lot of my frontline colleagues are working much harder than I am. So who am I to say that we're working too many hours when I can be at home working like this? So some of that plays into it. The other is there's so many opportunities to do so much good right now. So, I think having what feels like sometimes 2 or 3 jobs is one of those things that motivates me and I like about it, but it's also, you realize it takes away time from your family and other things you can do. So that was really, those 2 things were really driving how I scored below average for myself on that. But I mean, all in all, doing really well and thankful to be here and glad to be a part of this conversation.
That's great. I know everyone's met Dr. Cené before, but Crystal, are you willing to share something?
Yeah, thank you, Christy. It is so nice to see you guys, even though I can't see you, but just to be here again with you virtually. I think it was September when I was here before. And gosh, it just seems like so much has happened over the past, so much has happened over the past year. And I think there have been 2 big things that have, as I was reflecting on what it's been like for me personally, two big things that I've realized based on some experiences that have happened. And I think they're the importance of being anchored to something and recognizing what that is, what the anchor is for me personally. And then what I call the ministry of presence. So I'll tell you, when I think about COVID, it's just been such a year of loss in a lot of ways, loss of, jobs, economic stability for many people, a loss of hope, and emotional stability. We certainly have seen all of the, increased rates of depression and, suicidality and just hopelessness and then just the loss of normalcy of all of our, usual routines and our rhythms in our daily lives. The way that we sort of serve and work and volunteer and all of those things have changed so much. And I think when I was here before, you guys will remember that Randy Towns was with me. And I think about Randy, who I have just come to adore because she's so smart and talented and wonderful and just a great colleague to work with. And I think about her, she lost both of her grandparents to COVID in the span of 2 or 3 weeks. And thinking about others that I know who have died this year, and particularly one of my favorite patients who was 95, and he didn't die of COVID, but he died of lung cancer this year. And I, for the last month of his death, the month of his life, he was pretty with it and lucid, and I would go visit him in Graham every week on Sundays. That was my Sunday routine. I would go to his house and just sit with him, and that's kind of what and by this time, maybe around the last 3 weeks or so, he became a little bit less communicative than he was, and so often I would kind of sit there, and it was harder for him to talk. He could talk, and his voice was certainly lower. And so just the opportunity to sit with him each of those Sundays, it helped me realize how much that there really is a ministry in being present and not being able to fix anything or to change any, outcome. We knew what the ultimate outcome was going to be, but just the opportunity to sit and to do. And I sort of juxtaposed that in my mind with COVID. A lot of what we faced is kind of this isolation, and we're not able to do as much. So we've had a lot of time where we're kind of, our normal rhythms have been disturbed, but it felt differently, I think, when I could just be there and be present with someone in the moment and not worry about all the things I needed to do or should be doing. So it just, I guess I say all that to say I've learned a lot in this year, certainly thinking about the implications of what isolation does and loneliness. Interestingly, that's many of you know, I'm a health services researcher, and one of my main areas of research has been focused on social isolation and the health impacts of social isolation. And no one was really interested in that topic pre-COVID. So I feel a little vindicated that, yes, my area of interest has gotten a lot more publicity and hype over the past year. So it's certainly been a boom for me there. But it's also been more real, the health implications and of what isolation and loneliness do to people has been has been sort of sharply in focus in ways that it hadn't been pre-COVID. So I think those are the things that I've thought a lot about that, a lot of time of introspection, a lot of time to just be grateful that we're still here. And that led me to sort of my second point of just the importance of being anchored. With so much change this year, so much loss, it's really has been important for me to realize kind of what is my center, what is my anchor, and what kind of grounds me and keeps me stable. So I'm sure for each of you, all of you have different anchors, but for me, it's been nice to have that time to reflect and think about what that is for me. So that's how I've been.
Thank you, Crystal and Robb. And I know we're going to turn it to the presentation that you have, and Leslie can help facilitate that. But I would just add, in a spirit of gratitude that you were just reflecting, part of why I love my job is I get to recruit and invest in just remarkable leaders, as you see today, and then what's reflected in, as Rob and Crystal share themselves, just remarkable human beings. And so that part is just so fun. And then to watch them thrive and do great things and feel proud is part of what makes being part of UNC Health so just awesome. And then to be with you in this group who are giving and who are committed and who are with us in it, it just means so much. So thank you again for having us here. And I'm excited to have them share their work with you.
Okay. So Leslie,
that's right, Crystal and Rob.
should I start? Okay.
Take it away.
So I'll start. Rob and I are really excited to be able to talk about this initiative with you all. It's called Cover NC. We call it Cover NC for short, but it's really COVID. It stands for COVID Vaccination for Equity Reimagined for North Carolina. So Cover NC. And again, as Dr. Page alluded to in the beginning, we started this, or we were asked to develop an initiative that was directly in response to the disparities that we saw in COVID related hospitalizations and death. And those disparities disfavored individuals within certain racial groups, particularly Blacks, Hispanic or Latinx, as well as Indigenous Americans. You know we had the highest rates of COVID hospitalizations and death among Blacks and Indigenous populations, and we had highest rates of infection among Hispanic and Latinx and also Blacks. And so when we thought about this, and we thought about, our mission at UNC Health to serve all North Carolinians, and, there was the vaccine coming on the horizon and testing of various vaccines, we knew that we needed to have an intentional response that would help us meet populations at the greatest point of their need. And so we developed this initiative, which really was our main goal was to be a leader, for UNC Health to be a leader in equitable vaccine efforts. And we really wanted to create equity in the opportunity for vaccination. We know that among many populations, people were reluctant, or some were undecided, or in various stages of willingness to get vaccinated. And so we knew that we weren't necessarily going to be able to change people's minds in the short term, but we wanted to engage with them in a way that would create true, authentic partnerships where we can help them along this journey. And so we developed this initiative really, as I said, to provide equity in the opportunity. We wanted to eliminate any barriers that may exist for individuals within rural populations, within marginalized communities, historically marginalized populations. And we wanted to do that and balance that with making sure that we were responsible with making sure that people were able to get vaccinated in the week that the vaccines came out. And so, again, our goals were to ensure that the processes were safe and reliable and efficiently delivered. And we wanted to eliminate barriers that are faced by populations. It was really important for us to also engage with community leaders and community organizations in this process, both in identifying what the right solutions should be and in making sure that we then deliver those solutions to our target populations. Another one of our guiding principles was to make sure that we used multiple modes of providing individuals with access to the vaccine. So our predominant process had been that folks could go online, they could use their patient portal to schedule appointments to get the vaccine. But we know that many of our patients who live in rural settings may not have adequate access to the internet, or they may not have any internet access at all, or they may not have, they may have difficulties maneuvering through our systems, and they may not even be on the patient portal. And so we knew that we needed to have another process that would help address some of those barriers. So one of the things that we did a few key things. One of them was that the health system was very gracious in allowing us to set aside some of the vaccine supply to make sure that it went to individuals within these rural and marginalized populations in rural and underserved communities. So a portion of the supply that we received, we were able to set that aside so that we could give individuals who are at highest risk and who had high burden from the pandemic, they could access vaccination before all of those slots became sort of released to the general public. So we had set aside vaccine supply. We also had, we pushed out robocalls to individuals so that they got a message that says, hey, you're eligible and can get the vaccine if you'd like it. Call this number. We had a dedicated number that they could call in because, you know, for many folks, whether they're older, they may not be able to use the internet, may not be able to see well enough, they could pick up their phone and they could call us. And we had a dedicated, and we have a dedicated scheduling team who could answer those calls and get people scheduled. So we also, that was one approach that we used and continue to use. We also leveraged our community partnerships that we had developed from the COVID mobile testing work with the mobile van that was deployed in Southeast Raleigh for testing. We use those partnerships and other partnerships that we have to get names of individuals within communities who wanted to receive the vaccine, but for whatever reason had not been able to overcome barriers that would allow them to do so. So we got their names and phone numbers, and we would have our schedulers reach out to them. So people could literally be sitting at their house and someone would call them and say, hey, you know, we hear you're interested in getting a vaccine, we'll get you scheduled. That was another approach we did. One of the other things that we've done is we've created secure links that we can send out, we can give to our community partners. So maybe it's a community organization, maybe it's a church group or a religious group or a fraternity or sorority or a senior center. We can send them a link and allow them to click on the link. We give them a certain amount of time, and then we'll follow up with a phone call if they don't use the link before that time, where they can directly schedule. So now it eliminates some of the extra burden on our scheduling team that individuals can directly schedule into that link. So we've used a variety of approaches. Oh, the mobile van, of course, we should mention our mobile van is still active and still going out. We've gone to Selma, and we've gone to Kinston, and we're going to Durham. We've gone to lots of places, and we have more places that we're doing to make sure that we're meeting people where they are. And I think for the population that we're targeting here, it is very important to meet people at the place of their need. And so that's what we're doing. So we have been really, happy and with this effort. We've been intentional also about making sure that the folks that we're vaccinating are reflective of the community that we serve. So we created what we're calling a community reflection index. And what that means is that we look at all of our vaccine hubs, so the places where we're giving vaccinations, and we take a 20-mile radius around those so that we can get the surrounding community. And we look at the population, the demographics of the population in that community. And we make sure that the individuals that we're vaccinating are reflective of that community. That gives us a sense of, are we not reaching some populations within that community, or are we doing a good job in reaching others? And I'm so pleased to say that we have really increased our vaccine equity, meaning that we're getting the vaccine to people who need it and who want it. And we're making sure that our vaccination, the folks that we're vaccinating, are reflective of the communities that we're serving. And so I'm going to let Dr. Malone definitely talk through some more of those specifics. But thank you all.
Thank you, Crystal. You covered a lot for sure. So let me see if I can round some of that out. And I was just looking at the chat, and I see Marlene Rifkin asked a question about confusion and whatnot. And I mean, I agree with you. It's really interesting. I think our data shows that there's that confusion. That was a rough, 10 days or so when this opened up to teachers and this and that, but not the other. And I think it was there was confusion. Our appointments didn't go as quickly. But now opening it up, it's getting a bit easier. And in fact, the job that Crystal and I have been asked to do and help lead is easier as this becomes open and those rules become less and less confusing. So I do agree with you. So I think the easiest way to summarize a lot of this is how can you be both fast and fair in what you're doing? And I think that really, to me, summarizes it. And I'm sort of stealing that from Governor Cooper. I read in the paper that he was using that as a motto. And I think that's probably a good way to say it. I think that what Crystal highlighted was exactly right. And what's interesting to me is a lot of the decision making, the information, the analytics behind what we're talking about doing, and really had to be built like within the last month. I mean, this has totally changed the way we're thinking about addressing vaccination through the pandemic. I mean, it's interesting. This, health equity is something that our organization has prioritized, is going to invest in. We're spending a lot of time talking about ourselves, our culture, who we want to be, who our community is, and how to best serve them. And, to be honest with you, I think both Crystal and I see our response to the pandemic in this equitable way is our responsibility, but it's also an opportunity to really get a jump start on that health equity work. And that, I think, what we're doing now will go beyond the pandemic, because we've had to define what this means. If you think about it, how do you know that you're being equitable in your vaccine delivery? It is way more complicated than race and demographics and your zip code. How do you know that? So this idea of this community reflection that's a very UNC Health thing. And I think it really represents two things. One, it represents how do you make something that can be so subjective and biased, something that's objective is one, and that's important to us. And then two, the fact that we feel like it's our job and responsibility to take care of those members in our communities, those that we serve. So literally the way that we look at this is in that proximity around where our hospitals, our practices, and our vaccine sites are we delivering vaccines? Are we observing vaccine delivery matching what we expect to see in that community? And it is different. If you go to Kinston, North Carolina, you're 40% Black. If you go to Orange County, you're like, 14% Black if you're over 65 or older. That's vastly different situations, and each area and each community expects to see different things in your vaccination. So we had to learn that. We had to understand it and had to build those tools. I think that's a really interesting piece of this. And to me, something that we'll be able to take forward, as I believe this pandemic will forever change healthcare and the industry we're in, to be honest with you. I think that, as Crystal said, through these efforts, the groups that we've been working in the longest and have fewer of the confusing rules and regulations around them. For instance, if you're over 65 years old, we believe we've hit equity based on demographics, whether it be race or ethnicity, within those communities that we serve for that population. We are still working to vaccinate folks over 65 years old. They're still out there. They still need us. We're still looking for them. But we've done a good job there. In the younger population, we have a long way to go. We'll probably need different tools and solutions. We're bringing in a different view of this problem by focusing on social vulnerability. Social vulnerability, we're going to apply it in the same way we did poverty and demographics before. And this really takes all those things into account. It takes into account transportation, population density, housing, did I say education level already? Maybe I had. Income status, unemployment rates, all those things are factored in there. And that's really going to change and challenge us to say, are we looking in the right places? Are we vaccinating the most vulnerable North Carolinians? And I think, there's months worth of work to do. And I think, Christy mentioned, and I meant to mention this in my opening remarks, but I am proud of what we've done. I do think that each week we're getting better at it. I think we've proven we can be fast. Vaccinating over 250,000 individuals is quite amazing, I think. And I think that what we've got is a commitment to fairness, and we can demonstrate that we are closing that gap for real. Community partners, Crystal mentioned those before, and I think one of the things that we talk about is, and she mentioned it, is that what we hope to create is opportunity for vaccination. There's no mandates for vaccines, whether you're an employee or you're in you're a member of our community. We're going to give you what we think is complete information, accurate information, something that can be trusted, and be there when you're ready. That's sort of the way we look at it, in that we can't just, Crystal, you put words to this better than I'm going to put it, but you can't rush this. Many of these efforts are going to take some time, and that's where we really need our community the most. So going to the community, I think, has to be a lasting commitment because of that. Because when you go into some of these food banks or Dorcas Ministries in Wake County, or you pick one wherever you're from, they don't need a Band-Aid. They don't want us rushing in just to fix something right away. It's about relationships and long-term commitment. So I think the long-term aspect of this is going to be, how can we stick with those vulnerable groups, and how do we meet communities where they are? And that's what we're learning now. And we don't want to risk being fast for vaccines alone to mess that up. Crystal, anything you want to close out with that? I thought you covered a lot of ground to begin with. I was trying to give you the surrounding story.
Yeah, I mean, thank you, Rob. No, I think that everything you said was right. I do think it's important to say that, as Rob said, we're in this for the long haul. We are really so excited and, again, appreciative of the commitment that UNC Health and the School of Medicine have made to addressing health inequities, and to really trying to understand the, sort of structural and social drivers of disparate health outcomes across population groups. And this effort, this Cover NC effort, is really part of our broader strategy around health equity for the health system. And again, this is a new endeavor for us. Certainly there have been people within the School of Medicine and within the health system that are addressing issues related to healthcare quality. And so we'd like to think of how this work for equity is really helping us to advance our broader mission to improve the health of all North Carolinians. And so when we say all North Carolinians, we are making sure that everyone, all of those that we serve are included in that all, and that we're not leaving behind individuals, but we're doing that in a way that is a partnered approach, that's recognizing that communities have their own inherent strengths, that they're resilient, and we want to use an assets-based approach to thinking about how we partner with individuals. So we're really excited about that. I know some of you have asked around ways to help support us and to support our work. Financially is always helpful, but we don't want to discount anyone who can't contribute financially, because really at least for me, it's about carrying this broader message, understanding what is health equity, how do we achieve it, what are the structural barriers to achieving equity, what are the social barriers, how do we address those, how does that change how we provide care to patients, or how we look at our data, for example, or how do we engage our community. So all of those things are important. So I think in terms of other ways to help us, be committed to learning about, equity yourself and structural racism, and what those are and how those show up, and passing this along. We want you to be an ambassador with us and for us in this effort to achieve health equity. I think we have as a local North Carolinian, as a native from Eastern North Carolina, I love the state. I love the people of the state. And I want to make sure that we really are doing everything we can to serve them and to serve all of them. And so as many people who can be sort of equity ambassadors with us, that is helpful. We have some specific things that we, would love. We really want to be able to engage you all, if you're interested in learning more about this topic and helping us figure out who should we invest in, how should we partner, how can we bring in, community members or even other faculty within the School of Medicine or other schools to really think about making sure that we translate effective practices or promising practices, that we translate them into the care that we provide. We want to better leverage community members as community health workers, as navigators. I was just on a meeting right before this where we were talking about, one of the real challenges that we have are really being able to have a system that better supports our Spanish-speaking patients. So we have wonderful interpreters, as an example, who are, in person and phone interpretation services. But right now, we don't have a way for our patients to communicate with our Spanish-speaking patients to communicate with us through the patient portal, right? So we know that two-way communication, being able to kind of send your provider a message through the portal and receive an answer back, or to look at your blood work or your lab results, that's really important as an engagement strategy and helping people to really have avenues to invest in their care. And we don't have that available right now for Spanish-speaking patients. And that's a heavy lift. We were just talking about this, and we'd need, 18 new translators to be able to really sufficiently provide care for our Spanish-speaking populations. But that's a major equity issue. And so, helping us think through how can we overcome some of these barriers, and at least just being aware of them to help us advocate for change, I think is really important. And I have, a whole other slew of specific things that I'm happy to share with folks if you're interested. But I think there are many ways to support, and we appreciate and value all of them. So I'll stop there.
You're on mute, Dr. Page.
I am. I haven't done that mistake in a while. I see we do have some questions in the chat, some of which Rob or Crystal chimed in and answer, but maybe Leslie, we can go through and make sure that we've gotten them all. I can answer the long hauler question.
Okay, perfect.
Do you want me to jump there?
Yeah, maybe we start there.
Sure. There's a question from Richard Andre. Is there a plan to address long haulers in these communities? For those of you who haven't been reading stuff about this, these are people who have ongoing symptoms after their COVID acute illness, but continue to have fatigue or other problems that last longer. And we do, and maybe Rob or Crystal could chime in to add to what I say, but we do have a clinic opening, a multidisciplinary clinic led by our physical medicine and rehabilitation team, but partnered with other primary care and specialty groups to provide really well-coordinated care for these patients, because often it's not just one thing that they need, but it's a bigger picture to really help support them and help people get the kind of rehabilitation that they need to help move forward. So we're really, really excited about that. And that is also in partnership with the UNC Health Foundation. So we're super grateful to see the fruits of that giving.
Thanks, Dr. Page. I think we've covered all the questions in the chat. So if we want to turn to the questions that our participants submitted beforehand, that would be terrific. I can start off one and then we can just go back and forth if you'd like. But so this will be for Dr. Cené and Dr. Malone. Some people may say, why do we need this kind of effort focusing on minority populations for vaccinations? Why can't we do the same for everybody? So could you talk to us a little bit about the difference between equality and equity?
Am I on mute? Yes. Okay. Yes, thank you for that question. That's a really great question, and one that comes up a lot, and whether or not it comes up, it's on people's minds nevertheless. So let me just address that. So when we think about equality, obviously we all know that that's doing something equal for everyone. It's giving everyone the same program intervention. When we think about equity, equity is an acknowledgement that people are starting at different places. And so if you give everyone the same thing, if someone is starting from a lower place, they may come up, but the other group is also going to come up. So you essentially maintain or even exacerbate the disparity or the difference between them. So a more just approach is really looking at what are the barriers that prevent people from being sort of at the same starting point, and really trying to overcome those barriers for the group that starts at a lower place. So that inherently requires that you use different strategies. So it's an acknowledgement that people start from different places. So you can't just do the same thing for them because they're starting from a different place. It's the reason why, and I'm getting ready to go out on a limb here because I've never ran track, but I assume, and I'm told, that's why when you're running track, people start, you have the person on the inside row and they start further back than the people on the outer realm because you're covering a different amount of ground. So I think that's the difference. And so when we think about the health equity efforts that we're doing, not just for Cover NC, but just our broader strategy for equity, why did we have an approach? Why didn't we just let everybody sign up for the vaccine on MyChart? Well, it's because we know that not everyone has MyChart access. Not everyone has an internet. Not everyone knows how to use it. Maybe they don't even know how to read, right? So if we just say, here's the approach, and we're going to do the same thing for everybody. Everybody has to sign up via the patient portal. Well, for those groups who don't have access to that, then you're not really helping them. So we have to be intentional about identifying the barriers that groups face and then trying to help overcome those barriers so that we can get everyone to the place, to our goal, which is the highest attainable health possible. That's what we want for everybody. We want everybody to reach their full health potential and that no one should be disadvantaged from achieving that. So I hope that helps.
Yeah, I just, to me, I was thinking about this as Crystal was speaking, there's no one right solution. I can tell you that. The most definitive we've been at UNC Healthcare is to say that we're here for everyone that is eligible for a vaccine, coworkers, patients, non-patients, community members. We won't turn you away when it's your turn to take your shot. We've committed to sticking to guidelines from the state to keeping vaccines within counties. Now, what has changed is we've pivoted from being fast and delivering thousands of doses within the same week you receive them to being both fast and fair, not wasting a dose and getting it done. And we're doing those things with different modes. So I was thinking, none of us buy groceries in the same way. I don't even go into a grocery store anymore. I do the call ahead and curbside pickup, but I bet all of you don't do that. I think appointing for vaccines is very similar. We don't do walk-up vaccinations. We don't do drive-through vaccinations. We don't do events with cars wrapped miles long. We do scheduling, and there are different ways to get into that scheduling circuit. All appointments are available. Most appointments still go online. 60% are available online to anyone. 30% are through our 1-800 number. That's our community line where people call into, and then about 10% are carved out for this effort, where we're just making efforts within communities and basically door knocking by telephone is how we're doing it with that remaining amount.
Thank you for those, and I'll turn it to Leslie to ask the next question, but I can't help but add, for those of you who have experienced the online portal, which is amazing when it works, but if you've experienced that hit refresh, try to get an appointment, you go to the appointment tab and you're trying to figure out, well, can we get there? Can I make my schedule work? And then by the time you figure that out, it's gone. I experienced this a lot. It was really important to us that all of us, even people leading all these initiatives, are still going through the same process that all the patients are, so we can make it better. But in that, I spent a lot of time and have had a lot of education and happened to work at a computer a lot of my time, especially during COVID, so that I could do that for my elderly in-laws or for my elderly friend who's Spanish speaking. But it took, I felt like I won the lottery when I got these appointments, like, what, but then I couldn't help but reflect of they couldn't have done that. They don't navigate. Even, educated, whatever. They don't navigate the internet in the same way younger generations do. And so to be able to have these alternate ways, as Rob and Crystal are describing, for people to have access, to have equitable access, that's the piece, that it's not like we're saving it just for one population or another, but just trying to make it so that people who use things differently have equitable access to get that vaccine. And that piece has been important to us. And having experienced it on the other end, let's see why that's important.
Thank you, Dr. Page. I'm going to turn the next question to our mobile unit. You all talked a lot about our mobile unit during your remarks, and I'm delighted to say that Randy Towns is on the call with us today, that we can't see here or talk to her. A huge shout out to the work that she's doing there. But how can we expand the mobile unit? And will we continue to use this method of reaching the community once we go back to whatever our new normal is going to look like?
Yeah, so I definitely think that we want to continue to use the mobile unit as part of our strategy for, again, meeting people where they are. And I think that's a key theme within our work related to health equity. We know that, access to care in and of itself is a social determinant of health. And many individuals and communities face a lot of access issues. I think the van provides us with an opportunity to be able to go into where people are and be able to address some of their health needs and their needs for education and care and services, and doing that in a way that's compassionate and delivered by people who are trained and skilled and motivated, and who really have a servant's heart and who really are wanting to do that work and doing it well. I think one of the things that we want to expand with the mobile unit that can be in conjunction with it, but also separate, is we really want to use more community health workers. We want to use and invest in the people in these communities who may not be trained as physicians or any clinician, but they know their communities. They're experts in their community. They're expert in how to talk to people, how to reach people, and people feel comfortable and trust them. So we really want to expand the use of community health workers. I think that's another area where we would love some more support to be able to have that as a strategy, that maybe we have community health workers throughout our clinics. And again, they're not social workers. They're not, care managers. They play a specific function in really helping us better understand our community, so that we really can create kind of a accountable health community, if you will. We want to expand our reach. We want to move beyond the walls of our hospitals and our clinics to be able to go out into communities and have communities come into us, right? So when we have people from the community who are part of our clinics and who are part of our system, they give us insight into the way things work. And it helps to overcome barriers to trust. We've heard a lot. I know all of you have heard a lot with COVID about certain populations not trusting the healthcare system. I think this is a very crucial strategy for helping overcome some of those barriers. And it shows that we're investing and that we want to be partners. So I do think that we will continue to use the mobile unit. We have, one little mobile unit. We could use some more. And we want to reimagine how we use them and where we use them. And again, I invite you all to join us in that process. I am not a very top-down kind of leader. As a researcher, I use participatory methods, so I want to engage people in this process. I don't believe I'm the holder of any, sort of unique knowledge. I think that we all have a role to play, and so I would invite you to really send us your thoughts on what we can do, how we should do it. I don't have an MBA. I'm not a business leader, so I know some of you are. You have that expertise, and so I want to learn from you to help us figure out how to do this better and how to really fulfill our mission for the healthcare system.
Beautiful, beautiful. Well, there's a question here, or a comment and a question from Marlene Rifkin. That says, a shout out to your efforts with your Cover NC project. Hopefully the homeless shelters are included. Thanks for what you do. Are you engaging, or is there a way to engage or a plan to engage the homeless community?
Yeah, I think that's a great, that is a really great question. And we have not, so far, we have not engaged, but we have certainly talked about that. I didn't realize Randy was on the call, and it's so funny because I was just texting her. I said, sorry for multitasking, but that was my only text during this. But I did text Randy. I said, Randy, we have to talk today about homeless shelters and our strategy there. So trust me, we are on that. And I do know, I have colleagues who do work in this population, in the homeless population. And I think that certainly, that will be a critical partner for us. And again, it may be a great way to use our mobile unit. I know we've been trying to do a lot in Southeast Raleigh. There are certainly a lot of shelters there. One that a very dear friend of mine and a member of my church has been in and out of shelters for a couple years. And so I was just thinking of him when I saw your comment, Marlene, and thinking, oh, I've got to contact him and kind of get an entree into that shelter community that he's been a part of for a while. So I definitely think that that's something that will be on our radar, and we'll get an intentional plan together for. So thank you.
Great. I see there's another question. If I could just jump in that, and then there's an answer there. But the question is from Richard Andre again. Good questions, Richard. Do you tag your phone calls with UNC Health? I ask this because I ignore unidentified phone calls in order to avoid spam and political calls. Yes, all of us do. And so that's a really good question of how do patients know that you're not just spamming them? Rob, do you want to answer that one?
That's a tough one. That is one of my pet peeves too. I do the very same thing. I never answer a phone call, never, unless you're in my contacts. I mean, I don't blame you, Richard. We have tried to make sure all details that go out through these various mechanisms include clear designation of UNC Health. Despite that, so if you receive a text, it may come from an unknown number on some occasions, but the text leads with UNC Health, just like all of our reminders would. In some cases, the detail comes across from UNC when you get the text, depends on your carrier. So my understanding is for the calls that go out, we send what we can, but different carriers, phone systems will or will not display in the same manner. I mean, it's all over the place. It is very frustrating. So if that's why the ideal scenario would be known patient actively enrolled and using my chart, that when they get that notification on their phone, they know it's from a trusted, secure source, that is UNC Health. That's ideal. Anything other than that, it does get more difficult. But yes, that's something on our minds constantly, and we need better ways to keep connected with our patients for sure, so they know it's safe and secure.
I will say one of the other things, Richard, that we do in that regard is when we have been outreaching to our community partners, we actually, when they get the link and when they were doing the call, they call back in after they've gotten it to schedule, we would tell our partners like, hey, tell those that you shared this with, we're going to be calling from a 984 number or whatever number. So we would preempt them. And that actually worked well because some of our partners said, yeah, we told them that these were the prefixes, this was kind of the numbers to look out for. And that actually did increase the amount of people who actually answered the phone.
All right. So you're getting more lovely just comments in the chat. So I hope you all will take a minute, Dr. Malone and Dr. Cené, to read those. But
Okay,
we've come to the end of our time together and just very much appreciate your presentation today, Rob and Crystal and Dr. Page. Thank you so much for being with us. As we close out, I do want to just make mention that we will continue our Game Changers series. We're going to take a little break here and then start back up hopefully in April. So please be on the lookout for your invitations for that. And then I'll close by also saying that if you are moved by what you've heard today and want to support the work that we're doing, we're flashing up here our COVID-19 response fund and ways to participate in that, as well as our COVID-19 UNC Health website, so you can see that. And then lastly, of course, our Your Shot website for the vaccination. So thank you again so much for being with us today, and take a few minutes at the end of this. You're going to be prompted with a survey. If you'll just let us know how we did today, other subjects that you'd like to hear about, more questions around COVID-19, put them in your survey. Thanks again for being with us, and have a great afternoon, everyone.
Thanks.
Bye-bye.
Thank you.
Bye.